Yeah.
Welcome everybody to this live session. We're going to focus on Module 8. I've thrown in a little bit of terminology that may overlap some of the modules as well. Just before we got started, someone had asked a question about the page limit, and I am strict with the page limit. I believe it says in the instructions that I don't read past the page limit, and that is my practice. So it's better to work on being more concise than to take a chance with me. I think that was it from our sort of before we got started recording discussion. If there are any questions as we go, please, ask away as we go through the slides. I'm just thinking, I think there was something else I wanted to mention. Oops. Oh yes, the term paper is due November 9th. That's the thing that I wanted to mention. Let me just... Okay, my kids had me doing all kinds of Halloween preparation stuff tonight, so my head might be more on like making pie at the moment, but I will adjust quickly. Okay, so this is a good point for discussion in the chat, or if you want to use the microphone. You've been doing some good posts in terms of what ethno-specific agencies are, and I thought we could talk about them for a minute. So there's some prompts on the screen. What are they? What do they do? Where do you find them? That kind of thing. And I know some of you guys have been posting about this already, so throw it in the chat, raise your hand and talk, whatever you feel more comfortable with. They're usually support services. Okay, so that would go under what they do. Yes, Danielle. If you're talking, your mic isn't on yet. They're in neighborhoods or community areas. Yep. I don't know if CCAC would be an example because they aren't really ethno-specific.
Yes. I did a quick 411 search for Niagara, and I found probably like 40 or 50 different agencies around here. There was a lot of mosques, a lot of refugee centers. There's an Aboriginal center in Fort Erie. There's a couple of Italian places. They're really all over the place.
They are. I'm surprised to hear you bring up Fort Erie because usually it's easier to find them in larger centers than it would be in rural communities. Am I wrong? Is that a rural community?
Fort Erie is not really rural. It's kind of a faraway place in Niagara. I mean, Smithville and Fenwick would be more of the rural areas. Fort Erie is like 50 to 60,000, I think.
Okay.
I don't know, Tim, how many people are in Fort Erie? That's kind of like the hub. There's a lot of natives that live out in Fort Erie out that way. So it's kind of the more ideal place for it to be.
Yeah. Okay. I was probably thinking of something else. I see some of your friends saying in the chat that they help immigrants adjust to their community. Yes. Oftentimes when immigrants are new to a community, if they can find an agency that is, specific to their group, then it really helps them with the adjustment. And some people are talking about some different centers in different cities in the chat. Yeah, and they are agencies that belong or refer to, well, they're usually, now not all of them would run the same, but they're usually run by the group for the group kind of thing. Agencies like Big Brothers, Big Sisters, I don't know enough about them, but I'm pretty sure they're not ethno-specific. So ethno-specific would be more groups that focus on cultural practices for a specific group of people that share a common ethnicity. So you can find them in a lot of different ways. This is what I was hearing from you guys. Yeah, I would include the religious-based ones. Sometimes people may disagree with me, but I would. Wanabo Center for Aboriginal Health in Ottawa. Yep. So a lot of the places that I'm seeing come up on the list are from big cities. I do think that you're more likely to find these ethno-specific agencies in large cities. Now, depending on where you go, though, some of the smaller communities would also have some, but usually it's more in the larger urban centers. According to our text, people are more likely to accept help from people from the same cultural beliefs and values. Yes, same cultural beliefs and values. Good quote from the text. Okay, so you guys are doing a really good job discussing that in the chat and in the discussion boards. So I guess I will go to the next thing. This particular module kind of goes all the way from one, end of the life spectrum to the other. So I am going to talk a little more about end of life, which was the original title of this session, but then I decided to, try and cover a little bit from the beginning as well. What are some strategies that you would use with someone who is having a baby to try and be culturally competent during that birthing process? Ask them what is important to them. That is very important. Ask them to initially fill out a birth plan. Yes, a lot of places use birth plans now. Ask them how they deal with pain, right? Ask questions about how they wish to be cared for, who they want in the room, incorporate their cultural practices into the care plan. Ask them how they deal with afterbirths. With births after. Both apply. Ask them if they have any cultural preferences, have an understanding of what their usual practices are through asking them, or specifically what they might not want done. Alternative plans in case something goes wrong. Ask specific questions regarding their culture and how this can be integrated into their care. I'm seeing a lot of ask them. And yes, that is extremely important. You want to make sure that you ask them. That's the best way in any situation to practice cultural competency. And there's a lot of important things that happen around births in terms of, bonding and infant attachment. It's often a happy time, but there could also be some, loss that is experienced if something goes wrong. So it's good to have an understanding from the client and to ask them. Always ask them. I am trying to catch up with the chat. I'm happy to see that everybody is active there. And if I'm missing some things, I apologize. Family-centered care is really important. Value their choices, even if you don't agree with them. Ask the client without outside pressure of an entire family. Oh, that's a good tip. Try and speak their language if you can, yes, or have an interpreter. Oh, this is an interesting topic. So someone's mentioning that they have talked to someone who felt they were pressured into breastfeeding. Interesting. Ask them about supports needed after birth. Include family members when possible if the patient agrees. All right, so you guys have a lot of really good ideas in there. I feel like I'm skipping around topics, but it's because this particular chapter skips around topics a little bit. Oh, somebody else is commenting that they feel that they don't give you a lot of choice when you're in the hospital around breastfeeding. They do kind of push it. Now, I probably didn't feel as much pressure as what you were mentioning because I had made that decision before I went into hospital, but I can see what you're saying, that a lot of times they just kind of assume that that's what you're going to do. So maybe us as nurses need to be more understanding and empathetic for individuals who have chosen not to breastfeed. Maybe it has something to do with their culture, or maybe they just can't. And it can make yes, very good. It can make the mom feel inadequate. Yes, Rebecca.
So I actually had a girlfriend of mine who her baby just last May, and she happens to be a nurse as well. And she had made the decision not to breastfeed. And she has told me that she still felt pressured, and that a lot of the nurses are like, oh, maybe you should just try it. And so really not respecting her decision, which is a little bit troublesome. But
right.
Yeah.
We as nurses need to be very careful because we're in a position of power in that situation. And it's one thing to feel the need to inform a client about the potential benefits of breastfeeding, but really that probably should have been done before they were in labor, right? And so if they've made a clear decision not to breastfeed, it's not our place to make them feel inadequate because they have chosen not to. And like I said, maybe they just can't. Nurses are very pushy and rude when it comes to breastfeeding. Yeah, and I wonder if we're brainwashed in a way to think that sometimes that's the way to go. I'm reading a lot of comments about being pressured, and it's very unfortunate that so many people have been feeling this way about breastfeeding and experiencing that. Yeah, I would agree. Somebody could make a thesis statement out of this. Like, I know you probably all have your thesis statements down, but if you don't, this would be a current issue. I mean, there's a lot of media out there that, you know, tries to normalize breastfeeding, and that's a different issue about breastfeeding in public. But have we gone maybe too far in the birthing units, and we're pressuring people and making them feel inadequate, like people were saying, and maybe putting them at risk for like depression and stuff if they chose not to, right? Yeah, that's right. If the moms are already feeling overwhelmed with everything else that's going on. Okay, so somebody here is asking about why a woman would choose not to breastfeed because they don't understand. There are a lot of reasons. Lifestyle. So someone said lack of knowledge. That would be something that we probably would address before that birthing process. I mean, hopefully the lack of knowledge piece would have been dealt with in the visits that the person's having with their care. The word is escaping me at the moment. Prenatal care, personal choice, culture. Yes, those are all different factors. But I still don't think that we should be guilting them into it. So this example that Rebecca shared earlier was an example of a nurse. I'm going to make an assumption that that nurse maybe was informed around the benefits of breastfeeding. Maybe I shouldn't make that assumption because she's a nurse, but I would assume that, you know, she also was exposed to a lot of things around the benefits of breastfeeding through her pregnancy. Some people are talking about latching issues with the baby. It's time consuming, or I don't know if people are disagreeing with the time consuming part. Personally, I don't find it time consuming. Past experiences. Some people have a hard time with their infant latching. I actually, so I kept breastfeeding, but I had what's called mastitis. With my, sorry, maybe this is too much personal information, but basically, like, with mastitis, breasts can get inflamed and it can be extremely painful to breastfeed. Yeah, people, so I think we're getting into a little bit of a debate here in terms of the time consuming thing. I'd want to be careful not to get too far off track, but this is something that, you know, maybe would be valuable to continue the discussion on in the discussion boards. And someone else is bringing up a point of, you know, work being an issue. So I think there's a lot of reasons why someone may choose not to breastfeed. And it is very individualized, and I think we need to be careful as nurses not to come across as judgmental, because that can damage the nurse-client relationship, and it can also, like people were saying, make women feel I'm using the same word as you use, but inadequate. I think that it could lead to them, questioning things. And if they've made that decision, they should be allowed to focus on bonding with their baby and moving forward, not be constantly faced with questions by nurses every time there's a shift change, right? Oh, that's interesting. So some people are talking about some interesting benefits of breastfeeding. Okay. All right. I'm going to keep the discussion going just for the purposes of time, but this is a great discussion to try and continue in the discussion boards if you're interested. So let's just take a look at generic cultural competencies for a minute. This is a term that I think is worth defining, because generic cultural competencies are actually a good thing. I think sometimes when you hear the word generic, you think bad when you're thinking about cultural competence, but this term is actually referring to a broad set of knowledge, skills, or attitudes that allows us as nurses to provide care to people from diverse backgrounds. So it's a good thing to develop some generic skills that would be helpful. I don't know if any of you guys can think of some. I think, so when I look at skills and attitudes, I think about things like asking people questions and having an open attitude and that kind of thing. It might not be something that you think about all the time, but if it's not something that you already have as a nurse, then it's good to try and develop some of those skills. Being understanding, yeah. There's a lot of overlapping terms in this course. And compassionate, yes. So if you think about that, those types of skills would allow you to provide culturally competent care regardless of someone's cultural background, right? Oh, being aware of your own values and views, yes. Awareness is the first step to not having those things impact the care that you deliver to others. All right, we're going to talk a little bit about end-of-life care now. Medical assistance in dying. Now, I think some of you guys are fairly familiar with medical assistance in dying because you're doing your thesis on it. I see some people talking about some other generic skills in the chat, but I'm going to focus on the things that are related to what the slide is right now. It is a hot topic, I agree. So it is also fairly new, which is why I think that it's good to talk through medical assistance in dying and to pay some attention to it in this course. Medical assistance in dying is something that is now legal for people that are eligible in Canada. It does require the involvement of a nurse practitioner or physician. It's not something that as an RN we would go out and do on our own. Let me see. Oh, your work came out with a policy for it. That's good. It's nice to see some policies coming out. Yeah, I think it's happening more and more at different institutions. And I've seen some people talk about in their thesis statements the issue of whether or not people should actually be able to refuse in certain institutions to participate in medical assistance in dying. I think that's an interesting topic as well. So on the topic of refusal, if you as a nurse do not feel comfortable providing or participating in the medical assistance in dying process, you're not forced into it. You can transfer that care of that client to another nurse who can address the client's needs, but you need to provide care for that patient or resident, whatever you want to call them, until somebody else can take over their care. Now, you're not forced to actually participate in the dying process there, like the actual administration of the medication that's going to end that person's life. You won't be forced into that. Something else that's really important, though, is that you don't convey your objection to that in choosing medical assistance in dying to the patient at all. Like, that is definitely not something that you want to be doing. I'm just catching up with the chat. Yes, conscientious objection. So you can have a conscientious objection. You are not permitted to tell the client that you have the conscientious objection. You just do a smooth transfer of the care. It's also, I don't see this in my notes to say, but it's also important that you do not advise a client to seek to end their life. So it is still a crime to advise a client to seek to end their life. The client has to come to that decision on their own. Let the physician and the nurse practitioner take care of that discussion. And I see some people trying to weigh in on the faith debate. Again, at the risk of getting on a very engaging discussion that is slightly on the off-topic side, I'm not gonna pursue that one. You guys can pursue it for your thesis essays and talk about it in the discussion board if you want. Yeah, so there's a lot of criteria. I think it would be good for you to take a look at the CNO document that is linked here and familiarize yourself with that, because it is something that I believe most of us will come across in our careers. So it's good to be familiar with the guidelines from the College of Nurses of Ontario. All right, let's switch to HOPE. So good to know that HOPE is something that exists in palliative care. People can be dying and still be hopeful. Now, their hope might not be something that is a hope for a cure. Their hope might look different. What do you think hope might look like for someone who is dying? Hope for a peaceful passing, yes. Could be fulfilling some final wishes, yes. Oh my goodness, the chat is coming up really fast. I'm sorry if I missed some things. Hope for peace, no pain. Hope for the afterlife, yes. Pain-free to transition. Hope to go to heaven if they're religious, yes. Time with their family. Hope that dignity is maintained, yes. So there's a lot of things that you guys are bringing up that we as nurses actually have a role in helping that person achieve. Hope not to suffer. Hope to reunite with family and friends in heaven. Something else that I've seen is the individual hopes for good things for their family after their death. Was to see, oh, there we go. Grandfather's wish was to see all of his family before passing and traveled from out east to Ontario to fulfill this. Wow. Hope to have their wishes respected, yes. So as some people have mentioned, some people have a lot of faith, particularly in the end stages. And faith does not have to be related to religion. It may very well be related to religion, but it doesn't have to be a membership with some religious group. It is more an identification with agreed upon set of beliefs, and those would be possibly shared. But faith is a bit of a broader term than religion. So somebody may have faith and not be religious. I don't know if that makes sense. I'm not sure what that last question is about, because I was honestly looking at my notes of things to make sure that I said instead of looking at the chat at that point. Yeah, some people have hope in terms of that their wishes will be respected even when they can no longer consent, so that the person who is in that power of attorney role makes good choices for them. Hope to fulfill some goals. I don't know if that last thing can be clarified for me so that I can answer if that is a question. What I was just saying was that somebody can have faith and not be religious, because faith is not a membership with a religious group. Yeah, people can hope to not be a burden on their family, hope that their family will be okay with the grieving process. Yep. So it's all about expectations for future good, like it says on the slide. So when you're looking at hope in palliative care, it is really something that is dynamic. And hope in this case, instead of being something like related to a cure, is related to something that they feel is significant. So like someone was saying that their family would do all right with the grieving process, that would be significant, and as well as realistic. People will often, when they're experiencing hope, feel confident that this future good is going to happen, and it comes from inside, even if people are trying to poke holes in their hope. Oh, there's some interesting questions in the chat. So if someone wishes to have assisted death and wrote it in their will, but they become mentally incompetent, can they disregard the wish? I think that it would be highly dependent on the circumstance and at what point they became mentally incompetent. I would leave that up to the discretion of the person, the physician or the nurse practitioner. If there is a long period of time, I would say they wouldn't qualify anymore. Yes, Rebecca.
Pretty sure that unless something changed, but I'm pretty sure advance directives don't exist with MAID. It's one of my issues with MAID is that people, from what I understand, have to sort of end their life before they're quite ready, because if they do start to have that cognitive loss, then it becomes not an option, regardless of whether they've had the assessment already, because they're all of a sudden not competent, and maybe they've changed their mind, maybe it's something they don't really want. So as far as I'm aware, I don't think an advance directive type of thing is available.
I think you're right. Yeah. Is that the word? So I guess when I read the question, I'm trying to look back at the question. I'm having a hard time. Oh, in their will. Yeah, you're right. So if it wasn't in a will, it would be way far in advance. Go ahead, Jennifer.
As a matter of fact, you can't even be on narcotics before, because it causes you to not have your full mental capacity, and you have to be able to say that you want it right before they give it to you. They give you an opportunity to back out. So if you've there's some recent articles in the newspaper that there are, like, I think there's one that is tomorrow, November 1st. A woman has gained eligibility for this MAID assistance. However, she's terminating her life tomorrow because she's cognizant to do that, and she has like a brain cancer. So by the time she actually needs to utilize MAID, then she will not be able to give consent. So that's a big controversy. They're saying that you cannot have any kind of advance directives. No substitute decision maker can make that decision for you.
Yeah. You're right. There are a lot of people that are very interested in this. I think so. I see advanced directives as tricky. And I knew that, but I don't know. I guess I forgot about it in the moment because I knew that was one of the controversies around it. I think advanced directives are tricky because I guess people are saying, well, what if people change their mind and are no longer deemed capable? And so I think maybe that's where some of the sort of hesitation around it comes from, but I can definitely hear what you're saying. There's a lot of cases in which an advance directive would, in my opinion, make some sense because like that example that you're just saying, people are ending their lives sooner than they would because they're fearful that their wish is not going to be respected and then they're going to have to suffer. It is tricky because where do you draw the line? Yeah, I get it. And medical assistance in dying is something that's very new here in Canada. So I don't think that it's perfect. I think that there's, a lot of room. Somebody's mentioning mentally disabled individuals are also, not eligible. But there are cases I've seen some advocacy for enabling people when treatment doesn't work and this person is suffering that, doctors are advocating for allowing people to choose that. I think it's new. I think it'll probably get better with time than it is right now. And right now, it kind of depends on some of that advocacy work for changes to be made. Well, I see a comment that it's not fair to let some and not to let some people and not let everybody. Yeah, okay, I agree. I agree with Rebecca. We can be change agents, and maybe some of you people could choose to, that are writing your thesis on this, could choose to share your thesis outside of just the course. I don't know if that'll make a lot of difference, but if you were to put it somewhere else where other people could read it, it might have more of an impact than if it's just me reading it. That's my 2 cents about being open. Yeah, every situation is so different and so unique. So I agree. It's very hard to make blanket statements. It's also hard to make rules and regulations that's going to fit all of them. I do think that it's good that we have something right now. I think it's better than when we had nothing. I remember, reading about a parent who went to jail because he ended the suffering of his, I think it was his son at the time. And I remember thinking, like, how horrible. Yeah, assessments by 2 separate physicians. Like, I think it's something that we just need to figure out. And I'm happy that we've started figuring it out, not completely satisfied with it. I can also identify, there being a lot of tension around some of these cases that aren't currently allowed. Like, what if the family doesn't agree with the wishes of the individual because the family thinks that, that person with a mental illness can still get better? Like, what happens then? And there are people who with a mental illness may feel that there's no treatment when there is. And so how do you deal with that? It's a lot of pressure on physicians. Yes, I would agree. I do think it's something that will get better with time, though. Yeah, and so I think that in the healthcare field, we need to be careful not to let our own beliefs impede the ability of patients to engage in something like medical assistance in dying. We're back to this topic. I think it becomes tricky in that case, but I mean, physicians can refer as well to somebody else, and they can tell their patient that they believe that this person would be able to give them better care. It can just be as simple as that. They don't have to object or try and tell the person that they're wrong. I think that that's the key piece, is not to be judgmental and not to let your own conscientious objection impact that person's ability to receive good care. Okay. So I think I have a note on spirituality. Maybe I don't. I forget what I wanted to say about spirituality. Spirituality is a bigger concept than religion. I think that's the biggest point to make in terms of spirituality. So if religious practices and beliefs may be related, but spirituality is a broader concept than religion. Okay, let's see. Yeah, I don't have any notes under my slide either. I'm sorry, guys. I forgot what I was going to say there. When I was teaching this class before to a different group, oh, good. Yeah, Rebecca said that she's heard many people who have said that they are not religious, but they are spiritual. I've heard people say that as well. And if you look at the articles on spirituality, that would be very reflective of what the literature says. There's this interesting link to this thing called the Death Cafe. When Steve and I were teaching this class in the past, he's the one that that brought this up to me. And the idea here is that people go to this place to talk about death. People want to talk about death. I think sometimes our patients want to talk about death. And so how can we be open to talking about death? Death is a part of life. And this is a quote that we kind of changed when we were co-teaching, but the original quote that I used to use when I was teaching classes was that talking about dying doesn't kill you, just like talking about sex doesn't make you pregnant. And we changed it to playing hockey doesn't mean you're any good. I think the first statement might have been a little bit more memorable, let's say. It's the idea that sometimes we as nurses feel a hesitancy to talk about death, like it's something that we should avoid. And I don't know where that comes from sometimes, but patients, particularly those that are at end of life, might want to talk about it. And so how can we, like, not force them to talk about it, but open the door to be that person that they can talk to about death? Yeah, so maybe it shouldn't be difficult to talk about, but some people do find it difficult to talk about. And I would agree with Rebecca that we worry about saying the wrong thing. I know when I was a new nurse and I had to, like, I think it was my first or second shift, I had to go pronounce somebody, and then there was other deaths going on. It was a difficult thing to talk about at first because I don't think they do a good enough job preparing us for that in programs. Yeah, some people are raising some ideas of some questions why people might feel hesitant. It is a tough topic to approach. I agree, and I do think that things like that take some practice, but particularly if you're working in an area where people are dying, it is definitely a good skill to develop. Some people were raised so that they feel that comfortable to talk about it. Oh, good. So in somebody's mentioning that they think that it's probably related to culture. So if you grow up in a culture where people are open and talking about death throughout your life, even when you're a kid, it's not as difficult to talk about it, right? Yeah, I would agree that talking about death to a patient is easier than talking about death to your family member. Yeah, and so, like, how do you respond when a patient tells you that they just want to die? Like, what do you say? Yes, Rebecca.
So that's just one of the things that I always struggle with is when someone says to me, I'm dying. And sometimes it could just be kind of a random comment, not really within any context. And I never really know what to say. So sometimes I'll say, well, what's making you think that, or what's making you feel that way? Or sometimes, depending on the situation, like I might say, well, like we're all dying. Like I don't know how to approach the subject. It's not a good topic for me.
So I think, sorry, it's just echoing. I think personally trying to be open-ended about it is a good approach.
Yeah.
I wouldn't recommend we're all dying.
Yeah. I would agree,
Like,
even though it's come out of my mouth and I wish I could take it back at times. But yeah.
a closed-ended question would be, would you like to talk about it?
Yeah.
Because maybe it's just a statement, but I think often when somebody says something like that, they are trying to find someone to talk to. And
Mhm.
I think that it might be better to talk to them and not do a perfect job than to not talk to them about it.
Yeah, that's smart.
Thanks.
Well, thank you.
Oh, you're welcome. I see some good suggestions in the chat. Now, I do want to address a couple of them. I have also taught therapeutic communication, and I don't recommend why questions, just because they, I don't know if you use the Jarvis textbook, but Jarvis and some other people talk about them as possibly coming off as judgmental. So try and be as open-ended as you can. I would agree with the idea of asking questions, explore how they're feeling about it. I would try not to sound too much like, who is it? I don't know if it's Dr. Phil or like someone like that that's like, so how does that make you feel? Like, I would want to sound as genuine as possible, right? And, open-ended questions like, tell me how you're feeling would be a little bit better than I think something that sounds a little bit, I don't know if it's cliche is the right word. And I would, whatever I'm doing, I would stop, and so that I don't seem rushed. And then I would take that opportunity to try and help them out as much as I can. Talk about whatever it is that they want to talk about. Maybe they want to talk about a plan. Maybe they're worried about something and they want to talk about what they're worried about. Maybe, they want to know what it's going to be like. And so you can draw on some of your experience to say, death is something that is individualized. There are a lot of ways that it could happen, and ask them what they're hoping for. And I think if you're familiar with the area that you're in, your response to that might be a little bit different. Like it's a huge difference if someone is dying from cancer or if someone's dying in a long-term care center of old age, really, right? So I think it is always a challenging situation to be in. I think that you will get better with practice, and it's hard to practice something like this through role playing, but it's not a bad idea to try role playing it and to get some feedback from someone who works in your area and maybe has some more experience with dealing with death than you do. Okay. And presence, I see some people mentioning presence in the chat. Presence is also a good thing. So sometimes people just want a little bit of empathy, and maybe they don't want to talk. Maybe they want somebody to sit with them for a moment, and that could be uncomfortable too. But it's probably more uncomfortable for you because you're trying to judge yourself than it is for the client. Yes, and it is tricky because you don't want to share your personal beliefs about death. So you can ask them what they believe. Oh yeah, someone Jordan mentioned bearing witness. That's one of the terms in this class, right? I had them below the slides earlier. Yes, it is. Okay. Yeah, nice. People are happy with you right now. So I do think my best advice for that is to try and practice, and try and be open-ended. And you can draw on some literature. You can draw on experiences. Like, you want to remember, people are looking for some hope, right? So if they're worried about pain, You can tell them that, I don't know, maybe your organization that you have has a protocol, and people who are at end of life that are experiencing pain are get to have, I don't know, morphine every, I think it was hour the last time I was doing palliative care. It was very small doses, but anyways, and they are given that if they're showing any signs of pain. Like maybe the person doesn't know that that kind of stuff is available. That was a long-term care agency that I'm referring to. And maybe they don't want to talk about actual death. You're right. Maybe they want to talk about the life that they had. Maybe they want some reminiscence. Maybe they want to show you their pictures, right? Yeah, and pain medications in palliative care may be highly individualized. I know that a lot of long-term care agencies have a bit of a protocol, but they will change it if that medication obviously isn't working for the person. Okay, I don't have a lot more planned for this session, but I did want to mention a couple more things. Moving into the next module, I believe it is, you're going to be talking a little bit about culture as an iceberg. So I wanted you to sort of think about that and pay attention to that. And I think I really like this analogy that a lot of things around culture has to do with things that are hidden from view. So as you guys have been talking about tonight, we need to ask about those things because we can't see those things on the surface. And that's why we call it an iceberg. Also, someone's identity, who they identify as, has a lot of different components to it. And when you think about identity, it's a sense of being the same as others in some way. And it could be in one way, or it could be in another way. It could be in a whole combination of ways. All right. I think that's about it. I did have a question for you, and that was, I've just found out that I'm going to be teaching this course again next term, and I wanted to ask you if you had any ideas for improving anything in the course, whether it's assignments, the way the course is delivered, anything like that. Oh, sorry. Do you mean they share sameness as in age or interest? Yeah, so there's a lot of things that, you can identify sameness as, right? You might identify as a millennial. I don't, but apparently I am. You might identify as part of a religious group. You may find sameness with a cultural group. It may be a combination of those things. When somebody asks me about my identity, one of the first things on my list is that I'm a teacher and I'm a mother, like that kind of thing. Yeah, people call me millennial all the time, and it is kind of true according to my age. But funny thing is, Steve and I were actually doing a presentation together when I figured out that yes, I was a millennial. But now I know why they call me that in meetings sometimes. Okay, I got a suggestion here. Thin out the amount of stuff in Blackboard. Yes, okay, I would agree. Keep it to one spot rather than 2 websites with a crazy amount of links. Okay. Yeah, I was trying to make things better, but it may have backfired a little bit. I'm definitely going to have anything from an external website embedded for next term. Oh, a question related to the truth-telling chapter. Do people believe it's right to withhold a diagnosis or prognosis to a patient? That's a good question. Some people are saying no, that it's not right, that you should not withhold. Some cultures believe so. I don't know what that means. Some people are saying they think it depends on the patient's mental capacity. It's frustrating when the doctor doesn't give the diagnosis. Yes, now there's got to be a good reason why he doesn't give a diagnosis to a patient that is competent to receive one. Oh, someone's saying they like collaboration sessions. That's good to hear. Yeah, it is really cool. You guys are doing a great job of even what just happened here, bringing up questions. We're having great discussions. This is actually the best class for discussions in the collaboration sessions that I have led so far. Always struggle with that. We're not supposed to, but it's not always a good idea. So there's some debate going on with truth telling. I think that's another thing that's highly situational, because people are bringing up some good points in terms of if the person is mentally competent, that it is probably a good idea to tell the truth. I know I'm a horrible liar. I would have a really hard time lying. Thankfully, I haven't had to do that. And yeah, it's really hard to have black and white rules for something like nursing, because there's a lot of gray area. In terms of the course, some people are saying they like having choices. I have a cool idea for an assignment choice next term, but I don't know if I'm going to have enough time to build it before then. Unless somebody who's doing the assignment choice option wants to help out. I will keep doing the collaboration sessions because I do think that they are valuable. And I really like having them on a consistent day and time. That was a suggestion. I can't remember if it was this group or the group before. Help out how? So I was thinking about making one of the assignment choices playing a bunch of games. And so if the people who are this term choosing to do the learning object assignment want to try and build games that I can embed into Blackboard. I was going to call it Moodle for a second. Into Blackboard, then I could then make it worth marks for the next group. So for the assignment choice, they could play games instead of creating the games, essentially. Yeah, so they would learn stuff through doing the game. So right now, people who have chosen the learning object assignment are developing review materials that target things in the different modules. So if you guys develop some things, like, so I can do what's called like adaptive question release. I have a meeting to find out what else I can do, but basically I could create it so that, you know, you have to answer one question and get it right before the next one opens, and then it's kind of like a game that way. I'm not sure if I can put, I'm not sure all the different options that I can actually embed right into Blackboard, but I'm sure that I can find a workaround for things like crosswords and stuff like that if you guys are interested in helping out. Now, I just need to catch up a little bit on the chat. Yes, so learn things like terms, concepts, things that you think might be on the exam. Usually things that are on the exam are related to the key terms as well as the outcomes from the different modules, and I can change the exam to match what you guys create games about. That's not a problem. So the reason why the midterm is at 5% is because that's what it was the first time I taught it, and I didn't increase it. It's a very short thing, but if you think a higher percentage would be better, I can definitely make it a little bit higher. I do think I'll probably be using Lockdown Browser next term, though. So I don't know if that is stressful for students or not. I hear people saying that 5%, it was a lot of work for 5%. I think the idea around 5% was to have it more as practice, but I can easily bump it up to like 10 or even 15. I don't know what you guys think is appropriate. Crosswords would be very interesting. Yeah, so if you guys want to take some key terms and develop some crosswords, I would love to either program that in or have students just complete them and scan the thing and give it to me. But hopefully I can program it in. You can do it inside Moodle, so you've got to be able to do it inside Blackboard. Apparently Blackboard's won awards for being awesome. I don't know what those awards are. Is the final exam going to be similar to the midterm? The final exam's a lot longer. There's 90 questions instead of, what was it, 30? I would say some of the questions are similar in terms of the way that they're written. You probably won't see a lot of the same questions on the exam, though. Oh, well, if a lot of teachers are using Lockdown Browser now, I guess it won't be as stressful as it was before. 10% for 30 questions, okay. How many terms do I want? So I think some people doing learning, correct me if I'm wrong, but you're focusing on a particular module. If you're focusing on a module, use the terms from that module. If you want to pick terms from across different modules, go for it. It's just I don't want to waste people's time, so I would make sure that certain terms were on. Any of the terms that I talk about in live sessions would be good terms to have in the games. I don't know if that's a heavy hint. That might be a heavy hint. There is an exam review document already out there. Uh-oh, I've worried somebody. I don't know how I worried somebody. Does it focus on a specific chapter? Jose, I'm not sure what you're asking. Aha, thank you, Patricia. It was in the syllabus, the exam review document. I should post it in another place too. So, does it focus on a specific chapter? And is it from starting chapter? I don't know what you're asking. Aha, okay. Patricia solved the problem. So the final exam is the entire course. Part of the reason for that is that there's so much overlap in this course, particularly when we come to the last few modules. It's hard for me to say that I'm going to test just these certain modules. More definitions for the final. Honestly, I have to go over it again. I will be having an exam review session. Now, I have thrown some of my exam review slides into some of the other things. Like today, some of the slides are actually from what I would have done for an exam review, because there's a group doing a presentation on the same day that I'm doing the exam review, and I'm trying to keep these sessions to an hour. But I'll do the same thing next week, and I'll try and pull some of the stuff that I would have covered in an exam review on these. Yeah, so before you guys head out, let me know if you're cool with me posting this on YouTube. If I download it and post it on YouTube, which I've been forgetting to ask each time, it's a little bit easier for some people with slow internet to watch the recordings. And particularly for people who spoke, if there's something that you want edited out, let me know. The chat will not be captured. You can just send me an email if there's something that you want edited out. So I will hang around for a little bit to see if there are further questions, but I am going to say to the people watching the recording, thank you so much for watching the recording to the end. Please let me know if you have any suggestions for the course for next term, or if you have any questions regarding the course this term. Thank you again, and have a great rest of your night or day.